28-year-old man presents to general practice with 3 hours of mild left eye irritation following removal of drilling fragments 2 days ago. His temperature is 36.8 degrees Celsius and pulse is 85 beats per minute. Examination of the left eye, as shown in figure 14, is shown below. Which is the next most appropriate management? A. Chloramphenicol eye drops and discharge. B. Emergency eye service referral. C. Removal with a hypodermic needle. D. Sterile sweep with a cotton-tipped applicator. Or E. Topical lubricant eye drops and safety advice. The correct answer is C. Removal with a hypodermic needle. We can see in figure 14 a rust ring following the removal of a metallic foreign body. Corneal abrasions are superficial injuries to the epithelial layer of the cornea, most commonly caused by trauma or foreign bodies. Due to the cornea's rapid healing properties, most abrasions resolve within 1 or 2 days with appropriate care. The most frequent cause include mechanical trauma, such as scratches from fingernails, twigs, or even a misplaced mascara brush. Foreign bodies, like dust glass or metal fragments, can also lead to abrasions, especially in occupations involving grinding or cutting tools. Chemical burns from household cleaning products, prolonged UV exposure from sources like tanning beds or welding arcs, and improper contact lens use are additional risk factors. In some cases, patients may experience recurrent corneal erosions, where the corneal epithelium repeatedly breaks down, often occurring upon waking or after blinking. A history of a precipitating event is typically common in patients presenting with a corneal superficial injury. Patients with corneal abrasion typically present with acute, painful ocular discomfort, which is often exacerbated by blinking. A prominent foreign body sensation is common, alongside excessive tearing or lacrimation and significant photophobia. Visual acuity may be reduced depending on the size and location of the abrasion, while conjunctival hyperemia, redness of the eye, is frequently observed. In some cases, blepharospasm or involuntary eyelid closure may occur due to irritation. It is important to assess for additional signs of ocular trauma, particularly in cases involving high-velocity injuries, such as those sustained from hammering or machine work. A critical finding to look for is the presence of a rust ring, as seen in figure 15a, which can develop when a foreign metallic body becomes embedded in the cornea. If a more severe penetrating eye injury is suspected, urgent assessment is required. Signs of globe rupture, as illustrated in figure 15b, include the presence of blue, brown, or black material on the surface of the eye, indicating an open wound. A dilated, non-reactive, or irregular pupil, along with a protruding iris, may also suggest a full-thickness ocular perforation. Due to the potential for serious complications, all suspected penetrating injuries or globe ruptures require urgent ophthalmology referrals for further assessments and management. Diagnosis of a corneal abrasion begins with assessing visual acuity using a Snellen chart. This provides a baseline measurement to determine the extent of visual impairment. Next, a thorough examination of the eye is performed. A single drop of topical anesthetic is applied to relieve discomfort and facilitate assessment. The clinician should carefully inspect for foreign bodies, corneal clouding, opacity, or signs of infection such as infiltrates. An ophthalmoscope or a Wood's lamp is then used in conjunction with fluorescent staining and a cobalt blue filter to detect corneal epithelial defects. If present, these defects will fluoresce a bright green under the blue light, highlighting the area of injury, as shown in figure 16. In cases where staining appears to stream or change colour, an urgent referral is required to rule out more serious conditions, such as corneal perforation or an open globe injury. The management of a corneal abrasion follows a stepwise approach, beginning with first-line treatment. For loose, superficial foreign bodies, saline irrigation is used to flush the eye, combined with oral analgesia for pain relief. If the foreign body remains, second-line management involves the application of a topical ocular anesthetic, followed by gentle removal using a sterile cotton-tipped applicator. For more stubborn foreign bodies, a third-line approach using a hypodermic needle may be required. In cases of metallic foreign bodies, Follow-up within 1 to 2 days is essential to prevent rust ring formation, which can be managed with ophthalmic burr or hypodermic needle removal. Urgent referral is necessary in several scenarios, including suspected penetrating eye injury, chemical burns requiring immediate copious irrigation, retained foreign bodies, severe pain, irregular or dilated pupils, hyperemia, large or deep abrasions or corneal opacity. Complications such as iritis, infected keratitis, corneal ulceration, and recurrent erosion syndrome must be considered and managed accordingly.